Okay, so I'm going to switch gears now to talk about the key recommendations that have come out with the just released CDC opiate prescribing guidelines. So brand new guidelines, big focus on reducing overdose risk, and they have a whole variety of recommendations for changing clinical practice patterns. So I want to talk mostly about what these recommendations are, why they're important, and what might be some ways of more effectively implementing these in healthcare delivery systems, since some of them are going to be tricky to kind of jam into our current care delivery practices. Okay, so first of their recommendations is that non-pharmacological therapy and non-opiate pharmacological therapy should be first-line treatment for chronic pain, and that clinicians should only consider opiate therapy if the expected benefits for both pain and function are anticipated to outweigh the risks to the patient. The idea here, of course, is you should be trying other things first. Opiates are inherently risky. There are a whole bunch of other things that are probably more effective. So don't try them first. I will say, in my experience, that's already done in a lot of cases. There are many, many, many patients who've gone through a very long list of things before they get to opiates, and they still have trouble with opiates. So that's not going to solve all the problems, but it's a good starting place, right? Don't make your opiates your first line. Next part of this guideline is obviously what we talked about before, right? One, you gotta balance your risks and your benefits. So don't go giving people something that brings them into a high risk range. In terms of addiction or overdose, but also you've got to really focus on the function. So make sure that you're focusing on functional benefit and not just reducing pain severity. So we talked about that and why that's important. And ideally, if you're doing opiate therapy, you should combine it with non-pharmacologic therapy and non-opiate pharmacological therapy as appropriate. And I think that's obvious. And part of what I think about is, if you think about the ways that I suggested opiates seem to maybe help, they are being used not only as a pain reliever, but as a behavioral tool in a lot of conditions, right? You're using the opiate to encourage therapeutic behavior. That's going to do better if you have the patient engaged in non-opiate treatments like occupational therapy and physical therapy and cognitive behavioral therapy and the like, because those things can help shape the behavior and help focus on function, get people, more actively engaged, exercise therapy, et cetera. So the opiates are not only is this a way to reduce reliance on opiates, get people to try other treatments, but it's also a way to maybe make those opiates more likely to have more benefit. So what sorts of things do the guideline recommend? They recommend exercise and physical therapy, cognitive behavioral therapy, interventional approaches, so things like corticosteroid injections and other specialty interventional pain management approaches, and non-opiate pharmacotherapy, specifically acetaminophen, NSAIDs, tricyclic antidepressants, serotonin, norepinephrine reuptake inhibitors, and anticonvulsants. So all of those sort of standard approaches, I'm not going to go through it because our focus today is on opiates and how exactly to use each of these, but there are a number of things to try. They, again, just like with opiates, they're going to work better when you combine them. I will say generally, pain management does better the more multidisciplinary approach you take. So mixing things like exercise with analgesics, much, much better than trying one or the other alone. So the problems, of course, with this is that in many places, there is a very limited availability of physical therapy, mental health, substance use disorder, and other pain treatments. And so, it's all nice and good to send people to these first, but if they don't exist where you are, then, or your patient can't afford to go there, then you're kind of stuck. So one of the things we found is opiate prescribing rates tends to be a lot higher in healthcare systems where mental health and physical therapy are less available. So you can if you look at like the variation in opiate prescribing rates across hospitals, you can predict about 25% of that based on the availability of mental health providers in the clinic, and a full third of that if you count physical therapy and mental health treatment. So where these aren't available, people will turn to opiates for treatment because that is all there is. And I know that sounds obvious, but it's one of those things you have to advocate in your healthcare system for the importance of having treatments to send your patients with pain to, or the opiate problem is not going to go away. And frankly, clinicians are going to, if they have a distressed patient and there's nothing else they can recommend for them, they're going to prescribe the opiate. That's just common sense. Okay, their next recommendation is that before starting opiate therapy, clinicians need to establish treatment goals, including realistic goals for pain and function, and should consider how opiate therapy will be discontinued if its benefits don't outweigh the risk. So this is what we talked about already. Really, really important. We're focusing on function. We're developing goals to begin with. And we are planning when we're going to stop before we start. So we're writing into our treatment plan how we are going to evaluate whether or not the opiate trial is working, and how you're going to take somebody off if it doesn't work, right? So you want an exit plan to start. Otherwise, you will always be stuck in the place where you don't know. A higher dose might help more, but it might make it worse. But the only way to know is to try. If you don't sort of sit down and give yourself a limit, it's very, very easy to just get stuck in the cycle of increasing dose and increasing a dose and increasing dose. Second, we talked about this as well. Clinicians should only continue opiate therapy if there's clinically meaningful improvement in pain and function that outweighs risk to patient safety. So again, if it's not improving function, take them off. It wasn't a successful trial. You got to try something else. Third recommendation, before starting and periodically during opiate therapy, you should discuss with patients the risks and known risks and realistic benefits of opiate therapy, as well as what their responsibility and what your responsibility is for helping them manage their therapy. Here, the point is you need to talk to people about the risks of their medication. They need to know what they're taking. They need to know what not to do. They need to know that this is serious, right? You're not giving them something that they should give to their, toddler or their dog. If their toddler or their dog seems like they're in pain, you should not take more than prescribed, et cetera. You got to be clear with people, because what may seem obvious to you is not going to be obvious to all your patients. Some things that have been developed to help some of this is you can use standardized informed consent documents in process. The idea here is, rather than just leaving it up to every clinician to have unstructured risk-benefit discussions, you can put together materials that walk people through. These are the risks of opiate therapy. These are the expected benefits of treatment. And one thing I will emphasize that patients often can get confused with is they assume that opiates are numbing agents, essentially, that they're going to take the opiate and their pain is going to go away, right? Their pain is going to go to zero. Opiates dull pain. They may drop pain by 20 or 30%, but they don't drop pain to zero. And I think being clear up front about the fact that the opiates are just going to drop your pain a little bit, they're not going to wipe it out, is important, because otherwise patients, they may be getting the full effect that you could possibly expect from it, but they think they should have more, and thus, they should just take more, and hopefully the pain will go away completely. So focus both on the risks and what can reasonably be expected for benefit. So as I said, there's some places that have put in standardized informed consents, one to make it mandatory that everybody does them. That way you can, it's not optional. You don't have to make it up. It's all there. You're not going to miss something. You've gotten it handled. You can also, the nice part of having a standardized approved one is there have been in the past somewhat threatening looking risk benefit documents that make it That make it more sound like a contract with the patient. If you do this naughty thing or that naughty thing or this naughty thing, then I'm going to drop you out of care and I'm not going to be your doctor anymore and we're going to take your opiates away and things like that. And there's been a lot of those things that have happened. You really don't want to take that approach. You want to have a therapeutically aligned risk-benefit discussion, not a scary, threatening contract, so to speak. The other thing that's worked well for doing this are group education on risk, treatment, and responsibilities. And I've seen lots of primary care practices and other sites just basically require that all of their patients, rather than trying to do this, individually at every treatment visit, they've set up group education groups where that patients are mandated to go to before they can get their opiate prescriptions, where you can spend the time you need to spend in order to really do good risk education, orient people to the goals of treatment, and help them understand some of the basics about how pain and chronic pain work that hopefully will head them in the right direction. So that not only probably improves the quality of the discussions that happen, but it also takes the pressure off primary care to do those individually in each visit, because most people don't have enough time to do it right, frankly. The other nice part about doing it this way is it gives patients opportunity to learn from each other and to talk with each other, which I think is also sort of underused in clinical practice now. Okay, their next recommendation is that when starting opiate therapy for chronic pain, clinicians should prescribe immediate release opiates instead of extended release long-acting opiates. And the idea here when you're initiating opiates, you're starting with a patient who's opiate naive, who has no tolerance, and you need to titrate them up to a therapeutic dose. If you have short-acting opiates, it's relatively easy. They come on and you're basically giving them a dose as it's coming down. So the dose that they get on the first use of that drug is the same as the dose on the next and the same as the dose on the next. The problem with a lot of the long-acting formulations, and especially methadone, is that they're long-lasting enough that drug level builds up over time. So what happens is you take your first dose of methadone and you get maybe 20%, 25% of the total effect. The next day you're going to add to that, so your final dose winds up at like 50% of your total. The next day is higher and higher. So the dose compounds over days. It's not horribly hard to titrate this if you know what you're doing and you're seeing the patient every single day. But how many primary care doctors get to see their patient every single day when they're doing a drug titration? And so what happens in a lot of these cases, patients don't understand. They take their prescribed dose. The first day, it doesn't really work so much, so maybe they add a couple extra doses in there, or they take it a couple days and they're like, this isn't going to work. Or nobody's checking in with them about their ever-increasing sedation, and then they go to bed, one night in the titration process and they don't wake up. So this recommendation is essentially to prevent that. It's not that there's anything inherently better about immediate release versus extended release opiates, except that it's really, really hard to titrate the long-acting ones safely to get people to pain relief, and it's just not something you should try to do with infrequent outpatient visits. So that's the point of that recommendation. Next recommendation is when opiates are started, clinicians should prescribe the lowest effective doses, use caution at any dosage, reassess evidence of individual risks and benefits when considering increasing doses to greater than 50 milligrams morphine, and should avoid increasing doses to greater than 90 morphine equivalents a day, and very carefully justify a decision to go above that. So this is probably the most controversial of the CDC recommendations. Obviously, the the general concept of minimize dose is not particularly controversial at all. But suggested dose limits are substantially lower than what has been suggested in the past. And there's a large number of patients out there that are on a lot more than this. So one thing that I emphasize is the first part of this, right? It says when opiates are started, right? You need to prescribe the lowest effective dosage, and you need to set yourself limits of where you're going to go, right? And these should be your caution points. Don't go, if you're going to go above 50, start getting nervous. If you're going to go above 90, get really, really nervous and really make sure you're doing the right thing. What this I'm sure is going to get interpreted as, but is not meant to say, is that if you have somebody who's stably on, say, 150 milligrams of morphine, that you decide that, oh my goodness, the guideline says I shouldn't be above 90, so therefore I'm going to drop their dose immediately, right? Don't do that. That's dangerous, right? Like you can't, just because it would have been better never to get them that high doesn't mean that it's good to bring them right back to what would be safe. They're going to go into withdrawal. They're going to be destabilized. They're going to have pain. If you are worried about that dose, titrate them down really, really slowly, but don't